Good morning. Today we are live on the official Facebook and YouTube pages of the Department of Health. I am Dr. Casey Halili from the Public Health Services team. This is our town hall with medical practitioners. Welcome and good morning to our experts, resource speakers, officers of medical societies, allied health organizations, centers for health development, local government, hospital administrators and staff, fellow doctors, nurses, medtechs, and health practitioners. With the Delta variant and other variants of concern looming in the country and taking over our neighboring ASEAN countries, we need to ensure that all relevant sectors of society are apprised of the correct information on the Delta variant, among which and first are our medical frontliners and decision makers who provide direct care to our COVID-19 patients, and thus are collectively the foremost important sector in our fight against this evolving pandemic. While the method of transmission of the Delta variant has not changed, its mutations have made it a far more dangerous variant of COVID 19, significantly ramping up both the severity of the disease that it causes and the rate of its transmission. In this light, the Interagency Task Force, or the IATF, has already moved to tighten quarantine restrictions in certain regions and is preparing our health systems for the possible rise in cases driven by the Delta variant. Because of this, we need to ensure that all responses are carried out with a high level of excellence, especially as we seek to protect our health systems from being overloaded. This town hall focuses on providing accurate and updated guidance to all medical practitioners in the country regarding the latest clinical guidelines on COVID 19 cases and other relevant COVID 19 policies. Today, with us in the call is our DOH spokesperson, Dr. Maria Rosario Singh-Vergeire, Assistant Secretary for Administration and Financial Management, ASEC, Maylene Beltran, experts from the Technical Advisory Group, Dr. Marisa Alejandria and Dr. Anna Lisa Ong Lim. Later, we'll be joined in by our vaccine expert panel head, Dr. Nina Gloriani, and PhilHealth spokesperson, Dr. Shirley Domingo. But first, today to talk about the COVID-19 situation in the country and the government's preparatory response is the OIC Undersecretary of the Public Health Services team and the official spokesperson of the Department of Health. Ladies and gentlemen, Chief Executive Service Officer 2, Dr. Maria Rosario Singh-Vergeire. Yusek Rosette, the floor is yours po.
Thank you, Dr. Casey. Magandang umaga po sa inyong lahat at maraming salamat po for joining us today so that we can give you an overview of our COVID-19 national situation and what the government is doing for us to address this situation. Can we have the slides, Casey? So the impact of the Delta variant is now observed nationally and in selected regions and areas. Half of our provinces, highly urbanized cities, and independent component cities already showing increase in the number of cases and their healthcare utilization. Given ongoing Delta variant of concern transmission, we need to immediately address observed case increases, closely monitor healthcare utilization, and consider implementing higher community quarantine restrictions as preemptive measures to contain the spread of this Delta variant. All localities whose case and healthcare utilization are high and critical risk must urgently increase their health system's capacity to prevent fatalities from occurring, resulting from poor accessibility or availability of critical care services. All localities exhibiting case increases but healthcare utilization retained at low to moderate risk must likewise increase health systems capacity to prevent the healthcare capacity from being overwhelmed. Next slide. As of August 4, 2021, the total reported confirmed cases is 1,619,824, of which 3.9% are active cases, 94.36% are recoveries, and 1.74% are deaths. Looking more closely at our active cases, 96.77% of these are either asymptomatic, mild, or moderate cases. 3.23% or 2,043 cases are severe or critical. The top five regions contributing to these new cases being reported are the National Capital Region, Region 4A, Region 7, Region 3, and Region 6. The top five areas contributing to these new cases are Cavite, Laguna, Bulacan, Cebu, and Quezon City. Now, given our epidemic curve, we saw a decline since our peak in cases in the first week of April. Can we have the next slide, please? Since May, however, cases started to slowly rise again. Looking at the contribution of each of the regions to these cases, we can see that since the increase in cases, the National Capital Region has generally gone down. These are the dark blue bars, while Region 6, which are the light blue bars, and the other regions, which are the black bars, showed consistent increase and are now taking up a larger part in the total number of cases in the country. However, the decline in the National Capital Region cases seems to have stopped or slowed down. National cases saw an increase in the recent week. Cases from July 29 to August 4 recorded 7,650 cases per day, an increase of 1,651 cases per day compared to the previous week of July 22 to 28 at 5,998 cases. Next slide. Disaggregating our epidemic curve into major island groups and the NCR plus areas, we have noted that all areas are showing an increase in cases. NCR and the NCR plus areas are showing a steep increase. The rest of Luzon, Visayas, and Mindanao exhibiting slight increase in the number of cases. Next slide. Nationally, our two-week growth rate is positive at 28%. Our average daily attack rate, on the other hand, is still at moderate risk. It is showing an increase in the recent week at 6.19 cases for every 100,000 population. We would like to flag the National Capital Region, Region 7, Region 1, Region 10, CAR, Region 2 with high risk classification based on its moderate two-week growth rate and high-risk average daily attack rate. Region 7, Region 1, Region 2, and Region 4A also have high-risk ICU utilization rate. Note that the healthcare utilization rate is based on the maximum between the beds and the mechanical ventilators utilization allocated for COVID-19 in that said region. Aside from these high-risk areas, Region 4A, Region 3, and Region 12 are currently having a positive two-week growth rate, and Region 6 is at high-risk average daily attack rate among all the regions in the country. The National Capital Region maintains positive two-week growth rate and a high-risk average daily attack rate and is currently at high-risk classification. ADAR now is at 9.69 per 100,000 population. Next slide. We are also flagging two groups of priority areas. As of August 3, there are 49 flagged areas with moderate to high risk classification, which is based on the two-week growth rate and the average daily attack rates of each areas. And there is low to moderate risk healthcare ICU utilization. These 49 areas include 14 National Capital Region areas, Rizal, Bulacan, Cebu Province, and Mandaue City. There were 21 of these 45 areas with local Delta cases. We are also flagging 23 areas which have reached moderate to high risk cases classification and high to critical healthcare utilization and ICU utilization rates. The rest of the National Capital Region areas are included in this list, as well as Laguna, Cavite, and the cities of Iloilo, Lapu-Lapu, Cebu, and Davao. Also, 12 out of the 23 areas are with local Delta cases. Next slide, please. In the national level, deaths are declining. However, there was evident increase in deaths for Regions 3 and Region 7. Next slide. On biosurveillance updates of the 8,309 sample sequence assigned with a lineage as of July 28, 25.8% of samples were positive for the Beta variant or the South African lineage. 22.3% of samples were positive for the Alpha variant or the UK lineage. 2.6% or 216 samples were positive for the Delta variant or the Indian lineage, and 0.02% or 2 samples positive for the Gamma variant or the Brazilian lineage. Next slide. Among the 216 Delta variant cases in our country, 196 have recovered, 9 individuals have died, 11 remain active after validation and repeat RT-PCR conducted by our local epidemiology and surveillance units. 48 are returning overseas Filipino, and 165 are local cases. 3 cases are being verified if they are local cases or returning overseas Filipino. 54% or 117 are males, and cases belong to the age group of less than 1 to 79 years old. As for the vaccination status, 16 cases received 2 doses of COVID-19 vaccine, 11 cases received just 1 dose, while 49 cases were not vaccinated, and the rest is currently being verified. Next slide. The four-door strategy provides the framework for the National Emergency Operational Response Plan in the prevention and control of emerging and re-emerging infectious diseases. It embodies a set of operational guidelines that will ensure a complete and detailed rundown of actions to be taken at 4 distinct points of intervention to prevent and minimize the entry and spread of infectious diseases and to mitigate the possible effects of widespread community transmission. The Department of Health underscores that with this four-door strategy, we have delayed the entry of this Delta variant with the activation of the doors 1 and 2. Now that the country has detected local cases of the Delta variant, doors 3 and 4 are being activated. Door 3 would involve strengthening the implementation of the prevent, detect, isolate, treat, and reintegrate strategies or the PDITR to prevent further local transmission, while Door 4 will prepare and ensure our healthcare capacity is ready for a wide-scale community transmission by enhancing our PDITR plus strategies at all levels. Next slide. We have to ensure doors 3 and 4 of the door 4 strategies are in place and further strengthened to win this race against COVID-19 and its variants. For door 3, the national government is providing assistance to our local government units to strengthen the implementation of the PDITR plus immunization strategies to immediately detect, isolate, and prevent further transmission of possible COVID-19 cases. With the discovery of these new COVID-19 variants, there are a lot of new information generated. Hence, aside from the actual implementation of the PDITR plus strategy as a comprehensive response to COVID-19, we in the Department of Health had to ensure that all these actions are being communicated well to the public to lessen the uncertainty and anxiety of our kababayans. Next slide. For door 4, to be able to manage a possible increase in hospital cases, we have to ensure that the healthcare system is prepared regardless of community quarantine classification. Both the national and the local governments continue to increase the health system capacity to be able to manage cases. We have to ensure enough COVID-19 ICU and TTMF beds in these high-risk areas. Hospitals should implement the accordion policy to prepare for the exponential increase in cases in hospitals. The accordion policy is a conversion and reconversion principle that determines if hospitals should convert regular hospital beds to ICU beds, and it would help manage cases and save lives by ensuring that there are enough beds for critical and severe cases. All DOH hospitals were then required to develop their respective COVID-19 crisis action plans, which include aspects on bed capacity and allocation, health human resources for health, medications, supplies, case management, and referrals. Hospitals are called to share their contingency plans so that they could learn from each other's plans and adopt the best strategies. We also have to ensure that the country has enough supplies of COVID-19 medicines and oxygen tanks. To prevent shortage of COVID-19 medicines such as remdesivir and tocilizumab, the government must do inventory of medicines and ensure hospitals are well stocked. As an update, for our medicines, all DOH hospitals were instructed to stockpile on supply of COVID-19 investigational drugs. We have asked funding from relevant DOH offices and global partners, such as the Global Fund for dexamethasone and WHO for tocilizumab. In case of an exponential increase in the number of cases, the country is estimated to double its oxygen supply consumption. The government has to prepare for this by ensuring enough funds are in place to purchase medicines and oxygen tanks. Hence, for oxygen supply, DOH hospitals with oxygen generating plants were instructed to stockpile oxygen supply before the exponential increase in cases when the oxygen production capacity is greater than the consumption rate. For equipments, the Department of Health has 750 units of mechanical ventilators and 200 units of high-flow nasal cannula procured through the PSDBM to be delivered in these succeeding months. Lastly, we have to ensure that the health human resources for health augmentation through emergency hiring and continuous implementation of work arrangements for healthcare workers. Deployment of HRH to TTMFs, public and private hospitals must be continued, and there should be coordination with other government agencies to facilitate the deployment of these personnel from uniformed personnel groups such as PNP, PCG, and the BFP. As an update for our health human resources for health, the DOH already provided funds for HRH emergency hiring to all of our regional offices and DOH hospitals. This is good until the end of August. We also have requested for an additional budget for us to augment and extend until the end of the year. Next slide, please. To combat the anticipated rise in cases, we wish to highlight on the three action points that we must sustain and further improve in the weeks and months to come. First, active case finding and immediate isolation is crucial and is of utmost importance. When in doubt, immediately isolate and quarantine. Community-based active case finding and immediate isolation of those with exposure or symptoms will cut the transmission of this Delta variant. We need to hammer early and fast by proactively implementing stricter measures. This can prevent the devastating situation that plagued our neighboring countries. Stopping the transmission in its early stages prevents us from implementing measures that may further damage not only the health system, but also our economy. And lastly, we wish to reiterate that the minimum public health standards and vaccines work. While the Delta variant spreads faster and infects more people, the mode of transmission remains the same. Hence, the implementation of minimum public health standards and the administration of COVID-19 vaccines continue to show protection. Next. Building on what I've said, the Interagency Task Force and its implementing arm, the National Task Force Against COVID-19, are already ramping up three key actions leading up to the ECQ. These are preparing hospital capacity, limiting transmission, and strict implementation and preparation for our kababayans in this ECQ. To prepare our hospital capacity and prevent overwhelming the health system, the response cluster on health facilities have already instructed the hospitals to increase their bed capacity and ensure that there is a 30-day buffer stock of oxygen, PPEs, reagents, supplies, and essential medicines. In addition to this, instructions have already been issued to ensure that operational arrangements on the transportation of healthcare workers will be implemented. This week, we are also conducting town halls with our medical frontliners to reorient them with our guidelines. And these 2 weeks of ECQ is only meant to prepare and delay, if not prevent, the rise in the number of cases. Next, we emphasize on the need for 24/7 emergency operation centers in all of our regional offices and local government units. This will be properly guiding the triaging of patients in the most appropriate pathways. Hospitals are also being linked to our temporary treatment and monitoring facilities in order to ensure the transfer of asymptomatic and mild cases to our step-down facilities. Second, to limit the transmission and ensure strict implementation of the ECQ, we have requested the recovery cluster to consider reducing the carrying capacity of offices around. However, we have observed that some offices still, even with ECQ, still opt to have their employees report on site rather than adopting an alternative work arrangement. Through our response cluster on border control, we will set up and strengthen our borders and ensure that mobility policy checks are in place. This includes a strict implementation of our age restrictions. Next, through our response cluster on communities, we will be instructing all of our local government units to institutionalize and reactivate our barangay code teams for active case finding and immediate isolation of cases. And lastly, we will ensure complete daily laboratory data submissions to have a better understanding of what's happening on the ground. Our people also need to be primed on the implementation of ECQ. Our messaging will be more frequent to give everybody a sense of urgency for what's happening in our country. Preparations for the social amelioration program has already begun through the joint effort of our national agencies. And lastly, the National Vaccine Operations Center is preparing a contingency plan to ensure non-interruption of vaccination services and expand the coverage to the most vulnerable. Next slide. Our specific preparatory actions are divided into two, the community-based and the health facilities-based response. For our community response, the national government will be providing targeted attention to high-risk areas. We call on our local chief executives to utilize the barangay code teams to conduct active case finding. This can shorten our detection to isolation interval to just less than 5 days. We are expanding our temporary treatment and monitoring facilities for Oplan Kalinga so that we can enjoin patients to isolate in monitored facilities instead of their homes. The national government and local governments shall contract telemedicine providers for prompt triaging and consultations. Local border control shall be strictly implemented, and simultaneously, we are preparing transportation, hospitals, and burial sites. Laboratories, hospitals, and LGUs are to submit daily and without fail their accurate and up-to-date case data. To prepare our healthcare facilities in managing the continuous increase in cases, especially the severe and the critical ones, we have requested our hospitals through our One Hospital Command Center to monitor and secure the following: stockpiling of essential medicines, proper triaging and transferring of mild cases to TTMFs, adding 30% to 50% of their beds, ensuring healthcare workers' benefits, transportation, and accommodations, and telemedicine providers must be expanded and capacitated. Next slide, please. Let me also give you some updates from the DOH All Experts Group's interim recommendations for vaccination. For pediatric vaccination, we should delay this until our supply stabilizes. We should maintain and intensify vaccination of our vulnerable population above 18 years old. Children with comorbidities who have access to allowed vaccines may be considered to be vaccinated once supply stabilizes. As to the mixing of brands, it is not advised by our experts, considering the scarcity of safety data, moral and ethical implications, and the objective of the vaccination program to cover the most vulnerable population first. And as to booster doses, implementation to proceed once with sufficient evidence. Boosters are not needed at this time. So next slide, please. Likewise, the Philippine Pediatric Society has released a statement that reflects the stand of the DOH All Experts Group. It states that the current recommendation is to have older and more vulnerable age groups first, and they should be prioritized. Once the country will have adequate vaccine supply, children with comorbidities may be given precedence for vaccination. Next slide, please. For heterologous vaccination or booster doses, the PSMID has released a statement stating that, first, primary series of COVID-19 vaccines be completed as recommended using the same product at the prescribed interval. Second, fully vaccinated individuals do not need a booster shot at this time. There is currently a paucity of evidence to support recommendations for a COVID-19 vaccine booster shot for the general population. And third, the PSMID has stated that there is a need to await data on immunogenicity and safety from the ongoing booster and mix and match studies. Next slide. Lastly, I would like to emphasize the individual actions that we can do to prevent the transmission of COVID-19. If we all do this correctly and consistently, these are the best tools to protect ourselves, our peers, and our families and members of the community against these COVID-19 variants. First, ensure good ventilation and continue doing mask, ugas, iwas. Whenever we are indoors, we have to ensure that there is good ventilation. Transmission increases as more people go out and mix together. Second, get the job done. We need to help our loved ones and encourage them to get vaccinated, especially our elderlies and those with underlying medical conditions to get vaccinated as soon as possible. Get vaccinated when it's your turn and complete your doses as scheduled. Third, when in doubt, isolate or quarantine. We need to immediately isolate if we start experiencing any symptoms and consult your physicians through telemedicine hotlines. Coordinate with your barangay health emergency response teams to facilitate testing and facility-based isolation and quarantine. And fourth, share responsibly and think before you click. We are all responsible for the kind of information we create and share to our peers and loved ones. We need to combat misinformation and disinformation. Stay informed, get and share information only from reputable sources and organizations. Next slide. So before I end, let me take this opportunity to acknowledge the expert groups that had been providing their unwavering support and expertise to the department in crafting science and evidence-based policies and recommendations. First, the DOH Technical Advisory Group for COVID-19, who had been there since the beginning of this pandemic. They have provided us with guidance on how to improve our PDITR strategy while being anchored by the basic principles of the universal healthcare. Together with the COVID-19 Laboratory Expert Panel and the Task Force on COVID-19 Variants, we have significantly built our testing and detection capacity all over the country that allowed us to promptly respond to these threats posed by the variants of concern and interest. For our vaccination program, we acknowledge the Vaccine Experts Panel convened by the Department of Science and Technology that provides us expertise in research and development of vaccines in the country. The National Immunization Technical Advisory Group is the recommendatory body that guides the DOH in the formulation of policies, plans, and strategies for the implementation of COVID-19 immunization. The National Adverse Events Following Immunization Committee, or the NAFIC, is an independent body composed of health experts who provides evidence-based causality assessment of serious and cluster adverse events following immunization. Upon obtaining an emergency use authority or a CPR, vaccines are evaluated by the Health Technology Assessment Council or HTAC, which has been institutionalized by the Universal Healthcare Law. The HTAC also provides guidance on setting criteria for testing modalities, medicines, and vaccines to determine cost effectivity, which is very important in maximizing and delivering the UHC's promise of an equitable, accessible, quality care for every Filipino. With the help of all of our experts, we can assure the health sector and the public that our dynamic response to this pandemic is guided by the highest principles of science and molded by the best available evolving evidence. Together with us today are two members of our panels of experts. From the Technical Advisory Group, we have Dr. Ana Ong Lim and Dr. Marisa Alejandria. Maraming salamat po, and over to you, Casey.
Thank you so much, Yusek. Before we proceed to the next topic, for discussion today. We would like to acknowledge the medical societies with us today. We have the President of the Philippine Medical Association, Dr. Benito Atienza, President of the Philippine Thyroid Association, Dr. Nemencio Nicodemus Jr., President of the Philippine Academy of Ophthalmology, Dr. Maria Margarita Luna, the President from the Philippine Society for Reproductive Medicine, Dr. Angela Aguilar, President from the Philippine Academy of Cosmetic Surgery Incorporated, Dr. Angeles De Leon, from the Philippine Society for Pediatric Gastroenterology, Hepatology, and Nutrition, Dr. Marilu Tan, President from the Philippine Society of Hematology and Blood Transfusion, Dr. Jesus Relos, President of the PAFO Manila Chapter, Dr. Rosa Marie Flores, from the Philippine Academy of Family Physicians, we have Dr. Victoria Cruz, from the President of Adventist Medical Center Manila, Dr. Bibli Makaya, President of Las Piñas Medical Society, Dr. James Benedicto, and the President of PICOM Makati, Dr. Marie Amalia Perez. From the Philippine Lipid and Atherosclerosis Society, we have Dr. Adriel Guerrero. President of the Rizal Parañaque Medical Society, we have Dr. Anne Eleanor Damosasi. And the President of the Caloocan City Medical Society, we have Dr. Susana Caseria. And from the Philippine Physical Therapy Association, we have Mr. Michael Pereira Gabilo. Thank you and welcome for joining us this morning. And now, for our next topic for discussion, our next speaker will discuss our COVID-19 response principles: prevent, detect, isolate, treat, and reintegrate. She is a professor in the College of Medicine of the University of the Philippines and the chief of the Infectious and Tropical Diseases in Pediatrics of the Philippine General Hospital. From the Technical Advisory Group, we have our expert, Dr. Annalisa Ong Lim. Dr. Anna.
Good morning, Casey, and good morning, everybody. Good morning, dear colleagues. I know that most of us are already in the midst of preparations for the surge, and I know that many of us are, I don't want to use the word anxious, but I think it's a natural response, no? That we should be able to cope with the problems that are that we're anticipating. But I think what we have as an advantage right now is the effectiveness of the response that we've had so far in terms of delaying the entry of the Delta variant has been working to our advantage. So what I'd like to do for the next few minutes is basically to talk a little bit more about some options, some more tweaks, no, to our interventions that we can put into place to ensure that we have an even more effective and efficient response. So let me check if my screen is going to play properly. There. Are you seeing the, Casey, are you seeing the slide view or the presenter view?
Yes po.
Are my slides coming out okay?
Yes po.
Hindi presenter view yung nakikita ninyo?
Pero, yes, Doc. It's
So I
presenter
need to,
view.
okay, sige, let me just do that again. Sorry. There, is that okay?
We don't see the deck, Doc. We only see your video po.
Eto, okay na.
Yes.
Okay. So I'll be talking about specifically about the PDITR plus strategy. And again, as I mentioned, I'd like to share some options for tweaking this response so we can be even more effective. So I'm sure you're all very familiar with the PDITR response strategy. This is actually standard across different countries. No, we just call it by different names, but this is really based on very basic infection control and epidemiologic principles. And for the aspect of prevention, it's worth spending a few minutes trying to re-examine what we're doing right now to see whether we can still improve on our engineering controls, administrative controls, as well as the other health measures that we are currently implementing. So among the different aspects that we need to consider will include ventilation, reduction of the carrying capacity, as well as the appropriate use of our PPE and barrier modes of protection, all coming together to improve the prevent aspect of this strategy. So for ventilation, one of the things that I think we have to consider is that we keep on talking about this aspect of infection control, maybe without realizing that there are standards and also that there are targets that we can aim for, and that there's still so much more we can do compared to the current situation. So the PSMID living guidelines actually has done extensive reviews about some of the interventions that are in place right now with respect to non-pharmacologic interventions. And if you will review these recommendations, I think it's important to be updated and realize that there are certain interventions that now have very strong evidence that they really don't work. No, so I hope where you are right now, you're no longer using these ionizing air filters. No, so if you look at the air filters that you have in your areas, there are two kinds usually. There's a HEPA or high efficiency particulate air filter, which is okay, and these ionizing air filters, which are supposed to work by charging whatever dust particles that are floating around with negative ions, so they fall onto a surface. That one doesn't work against our enemy, which is the virus. Foot baths are also not useful. If you think about it, foot baths are supposed to help in infection control by disinfecting your footwear before you enter into a sterile area. But let's remember that our disinfection agents are only useful if they are not soaked with particulate matter and if they are changed frequently. So more often than not, the foot baths actually contribute to a safety concern. May mga nadapa, nadulas, no, dahil sa mga foot bath at wala namang masyadong or wala talagang idinadagdag na tulong itong mga ito. We all know already that misting tents and disinfection chambers are not helpful. And if you're in a facility that still uses this, let's move our resources elsewhere kung saan mas makakatulong. Then finally, medyo nauso din for a while yung mga UV lamps. And in fact, hanggang ngayon, meron pa siguro mga households or establishments na gumagamit nito. And outside of the clinic or hospital setting, hindi ito recommended. Now, how about conditional recommendations against? Yung mga physical barrier enclosures like aerosol boxes that are used during aerosol generating procedures are already now have a conditional recommendation against its use. Alam ko nung simula medyo nauso to sa atin and we were hopeful na sana makatulong ito in terms of preventing infection during intubation or nebulization, but really there's not much proof that this works, and it also actually contributes to difficulties in carrying out these procedures. So hindi na natin to ginagamit sa ngayon. How about recommendations for their use? So face masks, of course, are established as a means of protecting against infection, but we also have to appreciate the benefit of face shields. And in fact, may mga evidences naman and reviews na nagsasabi na pag pinagsabay natin yung paggamit ng face mask and face shield, may pakinabang siya, particularly in areas with sustained community transmission. So parang dinedescribe na niya yung buong Pilipinas. Now, for the general public, nagre-recommend na pwedeng gumamit ng cloth mask kasi yung exposure, degree of exposure nila sa mga taong positive for COVID ay ina-assume natin na mababa. Now, there's interim guidance now to recommend na maaring gumamit din ng medical grade mask for additional protection. High efficiency particulate filters, air filters are also also have a conditional recommendation for use, no? Karaniwan, pinaprioritize natin itong mga to for areas where it's not possible to have good exhaust systems. So kung medyo kulob or sarado yung isang lugar, perhaps in buildings or offices where windows cannot be opened or cannot be opened consistently. But we have to realize that these HEPA filters are rated for particular room sizes and occupancy. So hindi one size fits all. So kailangan tignan din kung appropriate yung filter para dun sa lugar na pinagagamitan. And in areas where there might be shortages of N95 masks, there was a time that decontamination was an option, and we might have to think about this once again now, no, kung kukulangin na naman tayo. And finally, yung protective physical barriers, yung mga acrylic barriers, no, might be helpful in areas where physical distancing cannot be consistently implemented. But of course, kailangan din nating tandaan, hindi lang naman droplet ang transmission, meron ding aerosol, so limited ang value. So, ang talagang merong strong recommendations for are the things that we actually do consistently. Number one, yung paggamit ng properly fitted surgical masks and standard PPE for healthcare workers not directly taking care of COVID patients and suspects. So ito yung paggamit ng blue and white mask natin, face shield and goggles and standard PPE. Siyempre iba, no? Pagka nandun na tayo sa COVID area, talagang balot na balot tayo, and this is also proven to be very effective. Also, for surfaces, kailangan din magkaroon ng regular implementation ng cleaning and disinfection protocol para hindi naman mataas ang viral load on the surface. Although we also realize na hindi naman ito yung main mode of transmission. And if we had to prioritize our actions, syempre ang una pa rin natin babantayan ay yung to make sure that the portals of entry, the mucosal membranes of the face, no, are adequately, properly protected. So, meron ding mga recommendations for, meron ding recommendations for appropriate personal protective equipment for our healthcare workers, no? So katulad na lang ng paggamit ng mask and face shield in areas in the outpatient setting kung non-aerosolizing procedures ang gagawin. And if in case contact with body fluids is anticipated, then kailangan nating magdagdag ng medical gowns and gloves. In the wards, the ICU, and the emergency room, kailangan medical protective mask of N95 grade or higher should be utilized together with appropriate protection for the eyes, which includes either goggles and face shields. So particularly in the ICU, no, we also want personnel to use other protective equipment like caps, disposable gloves, medical protective clothing, as well as disposable shoe covers. And for surgery, of course, no, we know the standard already is the baseline that I described, and idinadagdag pa natin yung option for double gloves, as well as making sure that our medical protective clothing is fluid repellent, either by the use of an additional apron or using fluid repellent sealed long gowns. Nabanggit ko kanina yung aspeto ng ventilation. And if you will look at this listing, makikita natin na karamihan actually ng standards for ventilation have been crafted for the workplace. These are joint issuances with DOLE or DOLE issuances that are intended for offices, workplaces, public transport. And I think this is one of the things that we can tweak, no? Also for our hospital workplaces, maybe the administrative offices or even the clinics. And also we can relay this information to the community so that we can utilize air ventilation and circulation to greater advantage. So, inuulit-ulit yung aspeto ng gamit ng open spaces and maximizing natural ventilation. And I think we really, really need to emphasize this because this is such a low-cost intervention in a country that can take advantage of the natural climate. No? Mabuti na nga lang at wala tayong winter, ulan lang ang kalaban natin at may paraan na ma-minimize no, yung impact ng pag-ulan. And if we are able to utilize our natural ventilation, our actual air exchange rate targeting 6 to 12 air changes per minute can actually, or rather per hour, can actually be achieved quite readily. Now, in those areas na naka-seal yung windows, kailangan talaga nating mag-isip kung paano lalagyan either ng HEPA filters or magkakabit ng exhaust. And sa public transport and even shuttles, no, we can re-emphasize the need to ensure that there is good air change, and this can be achieved by keeping the windows open. So the recommendation in the guideline, in the DOLE guideline, is to keep at least 3 inches open. And actually, yung seating din, no, kailangan mahalagang pansinin. So karaniwan, kung meron tayong driver na nasa harapan at yung passenger ay nandoon sa kanyang likod diagonally, yung bukas na bintana ay yung magkabila para nagko-cross-ventilate at hindi nasasagap nung nasa harap o nasa likod yung hinihinga nung kanyang katapat. So basically, we want to achieve good airflow, cross-ventilation within public transport or maybe within shuttles and maybe even your own vehicles when you're riding with the driver or maybe sharing the ride with somebody else. Now, balikan ko lang tong air change rate of 6 to 12 air changes per hour. Siyempre, ang susunod na tanong dyan, paano naman namin yan susukatin? Hindi naman kami HVAC engineer. At meron bang magagamit na device para mas madaling sukatin? So actually, matagal ng standard sa iba't ibang bansa yung indoor air quality na siguro hindi natin gaanong pinapansin dito sa Pilipinas kasi nga medyo matindi naman yung ating natural circulation or natural ventilation. Pero dahil nga iba na itong kalaban natin ngayon, itong si COVID, maganda ring isipin kung paano pa natin pwedeng ma-improve itong indoor air quality. So ang sinasabi is that for the reason why you want to monitor indoor air quality is your productivity can be hampered if there's a high level of CO2 within the workplace. So yung sinasabi natin, bakit ba tong batang to ay antukin sa classroom? Hindi lang siguro dahil nagpupuyat siya gabi-gabi at nagge-game. Kung hindi, pwedeng dahil hindi maganda yung air quality sa loob ng kanyang klaseng kulob na kulob at napakataas na yung CO2 level, kaya naman pala siya nag-aantok-antok at maaring yun din ang dahilan sa workplace. So, dun sa mga bansang meron na silang indoor air quality assessment, meron talaga silang targets of at least 1,000 CO2 particles and 800 CO2 particles for the offices. So, achievable ba to sa ating setting? Actually, may mga nagagamit naman na very low cost na CO2 monitors na maaring gusto nating subukan, no? Of course, meron talagang mas maganda yung standard, yung calibrated, pero siguro for practical use, no, it might be something that you might want to consider investing in. And your target is actually to achieve a level that is at least 600 ppm above what is standard for the outdoor setting. So, paano itatranslate yan? Kunwari, nasa opisina ka, pwede kang pumunta dun sa hallway mo na i-measure mo kung ano yung level dun sa hallway, kung saan medyo maganda-ganda yung ventilation. Tapos pagpasok mo dun sa loob, dapat plus 600. Hindi pwedeng more than that. Kasi otherwise, ibig sabihin, kulob na yung hangin ninyo sa loob and you have to figure out a way kung paano pagandahin yung circulation. Of course, importante ring isipin na magbabago yung mga numbers na yan base dun sa dami ng tao. Kaya meron din tayong guidelines kung ano ba yung maximum capacity sa isang room. Hindi lang yan dahil dun sa distancing requirements, but also we have to figure out kung yung air circulation na hinahabol natin ay ma-achieve din. So, I hope with this very practical tips, pwede natin itong ma-implement sa ating mga workplaces so that we can actually utilize, once again, this particular aspect in infection prevention and control. So I just like to share this very brief video with you, and I hope this will be helpful in understanding the concept of aerosol transmission better.
COVID-19 virus ay airborne na kumakalat sa hangin. Hindi lang ito nasa talsik ng laway o sipon na mabilis bumagsak. Kasama din ito sa hininga na tulad ng usok, lumulutang sa hangin, naiipon pagtagal at lumalayo. Ano bang ibig sabihin nito sa mga paraan ng pag-iwas? E di pareho din ng pag-iwas sa usok. Sa bahay, pag naipon ng usok, magbukas ng bintana o pintuan at pagalawin ang hangin palabas. Sa loob naman ng sasakyan, buksan din ang mga bintana para dumaloy ang hangin. Sa trabaho, ganun din. Laging buksan ang mga bintana at pintuan at pagalawin ang hangin palabas. Higit sa lahat, kung may gagawin tayo at kaya naman, piliin ang hindi kulob na lugar. Kung tulong-tulong tayo sa pag-iwas, kaya nating talunin ang COVID-19. Isang munting paalala mula sa inyong healthcare workers.
So this video is available on the HPAC Facebook page. I'd like to encourage everybody to share this para mas marami ding matuto tungkol dun sa aspeto ng air circulation and ventilation.
Ang COVID-19 virus
Okay, so actually, that's a prelude to some of the campaigns that are already very familiar to the public. No? So pinapaalala natin yung tinatawag na apat dapat. Hindi pa rin naman nagbabago ang mode of transmission ng COVID kahit na pinag-uusapan natin ng Delta. May bisa pa rin naman ang paggamit ng apat dapat. And also, no, in the same way, yung ating bida solusyon, which is utilizing, once again, mask and shield, sanitizing your hands, distancing, and also understanding and knowing about the correct information. So, other than ventilation, isa pa dun sa mga pwede nating i-tweak yung anticipating the need for healthcare supervision in the context of a surge. Alam natin na karamihan sa mga pasyente, pagka may nararamdaman na, ang default talaga ay magpa-ospital. Pero sinasabi naman natin na katulad pa rin ng ibang non-VOCs, ang Delta karamihan pa rin ay mild or asymptomatic ang presentation. So, hindi pa man din napupuno ang ating mga facilities, we already need to encourage our patients to seek the appropriate facility for their disease severity. And if the patient is asymptomatic or mild or kahit ibang categories like suspect or probable without indications for admission, dapat hindi natin talaga sila ina-admit. Ina-advisean lang natin silang mag-self-isolate for the appropriate period, no? And encourage that their household members should also be quarantined. I think the need that we need to anticipate naman from our patients is the fact that they want to be able to access care while they are at home and also to have the option to be transferred to the appropriate facility when the need arises. So I hope that even at this juncture, before the need arises, siguro yung ating mga regular patients and even our patients with urgent care needs or with comorbidities, siguro as clinicians, we need to already orient them about arrangements for telemedicine consultation or direct them to appropriate telemedicine portals that they can access if needed. And I actually say this now in the lay fora, no, na ngayon pa lang, hindi pa tayo nagkakaroon ng matinding problema. i-explore nyo na kung sino ba ang pwede nyong tawagan, saan ba kayo tatawag, so that if the need arises, nakaset up na. Hindi yung gagawin pa lang ito kung nandiyan na ang problema. So napakaraming options, no? Merong mga platforms that as clinical as health practitioners we can start to sign up in already, or we can refer our patients to our colleagues who are practicing telemedicine. We can refer them to the local government units that are already have already set up telemedicine portals. There are actually two ongoing telemedicine portals right now. Si PGH, ongoing pa rin yung tinatawag na telegabay para sa mga mild cases who are being cared for at home. And I know that the Office of the Vice President has the Bayanihan Telemedicine Portal that's still ongoing. So lahat ng ito na pwede nating i-explore so we're more familiar, pwede nating i-share sa ating mga pasyente, pwede na tayong mag-set up ng system. Pwede na natin silang i-inform na kung mag-positive kayo, ito ang ating sistema. Again, no, to anticipate na hindi tayo matataranta pagkadating ng panahon at nangangailangan na ng tulong. Now, meron tayong PDITR. Ano yung plus? Ito yung vaccination. And hindi talaga matatawaran yung need to be able to implement this as quickly as possible in the most appropriate manner possible. Marami nagtatanong, ayaw ng A2, ayaw ng A3, hindi ba natin pwedeng ibigay na sa A4, sa A5, sa B at saka sa C? So marami ding tumitingin itong konseptong ito. And kahit ano pang paikot-ikot natin sa mga numbers, the fact remains that if we are not able to cover our A2 and A3 optimally, ma-overwhelm pa rin talaga ang ating healthcare system. Tandaan natin, bakit ba tayo nagsasara? It's because our healthcare capacity is no longer able to cope with the demands. Who are the ones demanding our healthcare facilities? It is precisely our A2 and A3 who are the most at risk for severe disease and death. So therefore, it stands to follow that if we are able to protect our A2 and A3 optimally, then we should be able to manage any potential or the potential surge that we are already anticipating. So maganda-ganda yung coverage ng A2 natin sa NCR. The latest data shows about 60+%. Pero for the rest of the country, if you average it all together, we're only covering 30-something, wala pang 40%. So malayo-layo pa ang kailangan nating abutin sa A2. So siguro kung meron tayong mga kakilalang A2 sa sarili-sarili nating networks, let's take the time to talk to them, find out what's happening, bakit ba ayaw nilang magpabakuna, or baka naman ang problema is gusto nila pero hindi lang sila makarating dun sa bakunahan. And we can probably use our influence as healthcare workers, no, with our local government units, with our barangays, to be able to find a way to vaccinate these A2 and A3 individuals who are still unprotected. So, ang tanong din dito, or ang tanong na kailangan din nating i-anticipate, no, before I end is, kailan naman tayo matatapos sa ECQ? So, ito ang ating targets. As with any intervention, no, kung tayo gumagamot ng individual patients, parati tayong ano ba ang gusto nating ma-achieve, hanggang kailan ba tayo magagamot? So sa health system, meron ding dapat ganoon. Kailan ba tayo aalis sa ECQ? Well, unang-una, tinitignan natin kung yung benefits of opening up already outweigh the risk. And of course, we want to be able to see that transmission is already controlled, that our minimum public health standards are consistently complied with, and that the capacities we're anticipating and preparing for are already in place. We want to make sure that the risks for outbreaks are minimized for the vulnerable, and of course, this includes our vaccination program. And finally, no, we want to be able to ensure that our stakeholders, the general public, the community, are engaged, aware, and participating in the preparations for gradual reopening. So with that, let me turn the floor back to Dr. Casey and for the rest of the program. Maraming salamat po.
Thank you so much, Doc Anna, for reminding us again and recapping what our PDITR strategies are. In our call na po, with us today is the head of the vaccine expert panel, Dr. Nina Gloriani. Also with us today is the President of the Philippine Society of General Internal Medicine, Dr. Reynaldo San Luis III. Other medical associations with us today would be the Philippine Academy of Medical Specialists, Philippine Academy of Clinical and Cosmetic Dermatology, Preventive, Regenerative, and Integrative Medical Alliance, Philippine College of Emergency Medicine, Philippine Pediatric Society, Academy of Filipino Neurosurgeons, Philippine Society of Endocrinology, Diabetes, and Metabolism, Philippine College of Physicians, and um, Manila Medical Society, and the Philippine Society of Nephrology. Now, for the next topic, to discuss our updated management guidelines for COVID-19 is Professor of Clinical Epidemiology and Infectious Diseases at the UP College of Medicine, a clinical professor of the UP Philippine General Hospital. She is a director of the Institute of Clinical Epidemiology of the UP National Institute of Health and currently the president of the Philippine Society for Microbiology and Infectious Diseases, a member of our technical advisory group, Dr. Marisa M. Alejandria. Good morning po, Doc Isa.
Good morning, Casey, and good morning to our colleagues. Mga kasama natin sa laban dito sa COVID-19 pandemic and infodemic. So, can you see the screen?
Yes po. Yes po, Doc.
Can you see my screen?
Yes po, we can see it po.
Okay. So, as mentioned, this last segment will be a review on the screening, diagnosis, and treatment of COVID-19. Okay. And as Dr. Ann has emphasized, that prevention and early detection is primary in the control of infectious diseases, particularly COVID-19. Kaya yung ating strategy, PDITR, nauna talaga yung prevent and detect sa infectious diseases. Now, if we are unable to prevent and detect early, then we move to the treatment and recovery strategy. So this is now where we also need our guidelines on how to effectively manage COVID-19 to reduce morbidity and mortality. So for the next 20 minutes, I'll be highlighting key recommendations from our Philippine COVID-19 Living CPG. And for those who would like to access this, including the details, the evidence summaries, you can go to our website, pisme.org website, and it can also be accessed through the HTAC, DOH HTAC website. Okay, so let me just quickly share to you the process on how we generated the recommendations for this COVID Living CPG. As you know, initially in the start of the pandemic last year, we just started off with interim guidance from our society, summarizing evidence. Then as the evidence quickly evolved, we really realized the need to synthesize the evidence and also get multidisciplinary opinion from our experts in the different societies, as we know now that COVID-19 is a multidisciplinary disease. Okay, so in drafting the recommendations, we have 3 groups of committees working. So we have the steering committee, which guides the scope and the identification of priority practice questions, which will then be reviewed by the technical working group. They will be the one to do the systematic review of the literature and then synthesize the appraised evidence and then draft the recommendations. And these recommendations are presented to the consensus panel to be vetted upon, and they will vote on these recommendations not just based on the quality of the evidence, but taking into consideration also issues on access, equity, resource use. No? So you can see here the different societies that are represented in the consensus panel, as well as the steering committee. So the practice questions are generated in collaboration also with the Department of Health. And we welcome your feedback, no, on the guidelines. And then if there are questions that need to be addressed, then we also would welcome them. Okay, so then as the recommendations are vetted upon by the panel, then these are then relayed to the Department of Health for review and adoption into policy. We also presented them to the Health Technology Assessment for them to work on the cost and benefit analysis. Okay. So that's the COVID living CPG process. And then to help disseminate also the guidelines, the HPAC, no, through these member societies, took the initiative to convert the guideline recommendations into user-friendly algorithms, no, to guide the practitioners. And this has also been updated in August. And this is the navigation table, which contains the algorithm. So each of these hyperlinks, if you click this, will lead you to the algorithms. No? So from how to manage asymptomatic patients down to post-mortem care. So I encourage you also to access this at the PSMID website, no? And then linked also to the HPAC website. Okay. And just like to share also that we are currently updating our Living CPG, the guidelines, no, because as you know, the evidence has evolved. So since we've started this Living CPG process last December, we've had 3 or 4 updates already, and now we're again updating and hope to come up with the updates by end of this month. No? And together with that will be an update also of the algorithms. Okay. So that's where we are. So let's start off with screening and diagnosis. And as mentioned, with the Delta variant, the incubation period, mode of transmission remains the same. Okay. Since the start of this year, we've been actually managing variants already, alpha, beta, gamma. Now we have the Delta variant, which you all know is the difference is it's highly transmissible, higher viral load, but there's still a question on whether there is really prolonged duration of shedding, and then whether that virus that is shed is still infectious. Okay, so incubation period remains at 2 to 14 days after exposure to the virus. So we continue to recommend to screen, no, for COVID-19 by asking for any influenza-like illness symptoms and the typical COVID-19 symptoms like so diarrhea, anosmia, dysgeusia, okay, fatigue, muscle pains, okay, headache, cough, sore throat. And then together with the screening for symptoms is screening again for history of exposure to suspect, probable, or confirmed cases either through travel, through your occupation or work, okay, or in the household. Okay. And all symptomatic individuals, regardless of vaccination status, who are suspected of COVID-19 should undergo testing for COVID-19. And then what tests are recommended? So there are 3 available tests, not 3 groups of tests. The nucleic acid amplification assays, which includes your RT-PCR and gene expert, then you have rapid antigen test, and then the antibody test. For diagnosis, it's still RT-PCR, including gene expert, which is the diagnostic test of choice to confirm the diagnosis of COVID-19. Now, an alternative test, no, that can be used is the rapid antigen test. Its advantage, as you know, is rapid, is the turnaround time, and based on systematic review of literature, it's sensitivity range from 70 to 80%. And so the best time to use a rapid antigen test is among symptomatic patients within the first 7 days of illness. And the recommendation is to use kits that are in the WHO EUL list or our FDA approved kits with sensitivity of 80% or more and 97% specificity of 97% or more. And examples of these kits are the PanBio and the Standard Q by SD Biosensor. Okay. So rapid antigen test can be used as a substitute in the community or hospital setting where RT-PCR capacity is insufficient or where the turnaround time is critical to guide patient forward management, especially if you have to free up the beds in the ER. So rapid antigen tests can facilitate faster detection. No? So, and then in community outbreaks as well, no, for quicker case finding, like now that we have a highly transmissible variant, we want to quickly detect and isolate. So rapid antigen test can be an alternative, no, for early detection and case finding. Now, how do we interpret the results? No? So for symptomatic close contacts, no, if it's a positive result, then it's considered already as the final diagnostic test result. No need to repeat. No, but if it's negative and you are highly suspecting, then you do an RT-PCR. So for symptomatic close contacts who tested negative for rapid antigen test, as well as asymptomatic close contacts regardless of antigen test result, shall undergo confirmatory RT-PCR test. Okay? So if you're highly suspecting and it's negative, then that's when you have to do an RT-PCR because the sensitivity of rapid antigen test among asymptomatics is low. No? So we need to do, so there's a high risk of false negatives. Okay. Next set of tests is the antibody test. Okay, so when do we use the antibody test? So we suggest the use of antibody tests with high sensitivity and specificity to determine seroprevalence among adults. Okay, so preferably use the laboratory-based assays, no, ELISA or ECLIA. Okay, and then these are the rapid antibody tests that have been evaluated by RITM with 98% sensitivity and specificity. Okay. So in the, we do not recommend using antibody tests detecting IgM to determine COVID-19 prevalence, and we recommend against the use of rapid antibody tests for seroprevalence. Rapid antibody tests can be used in a clinical setting in certain subsets of patients who are coming in already on the second or third week of illness, and they give you a negative RT-PCR or a negative rapid antigen test, but still you are highly suspecting, then you may do a rapid antibody test. So that's the case scenario where you can do a rapid antibody test towards the second or third week of illness, just to supplement supplementary diagnosis in situations where the RT-PCR remains negative and you have ruled out other differential diagnoses. Now, just added this genome sequencing, no, because we've been having a lot. I think there have been a lot of discussions about the role of genome sequencing, and then how come we don't get the results on time. So just to remind everyone that genome sequencing is not really for point of care or to guide individual patient management. It's really an epidemiologic tool, no, for surveillance, no, to determine if the variants have entered our country, and then the extent of transmission of the variants through the analysis of the phylogenetic trees. And it is also more to characterize or monitor the impact of variants on transmissibility of the disease, severity of the disease, monitor its impact on vaccine effectiveness, performance of diagnostic tests, effectiveness of treatment interventions such as convalescent plasma and monoclonal antibodies. So basically, it's meant to inform policy and guidelines to, which is what we've done. No? So we've used it to guide us whether we are going to escalate our restrictions, okay, our community restrictions. So it's really more for a population level management rather than individual patient management. Now, before we proceed to management, let's just review the surveillance case definitions. This is the December 2020 updated WHO suspect case definition. So acute onset of fever and cough, or 3 or more of the following. So if you have this, and then one of the following epidemiologic criteria, okay, so working in an area with high risk transmission, residing or travel to an area with community transmission, or working in any healthcare setting. So you're a suspect case, or patients with SARI or severe acute respiratory infection with onset within the last 10 days, requiring hospitalization, or an asymptomatic person not meeting any of these epidemiologic criteria, but with a positive rapid antigen test. So this one will need to be confirmed by RT-PCR test. Okay. So anyone who falls under this warrants testing. Okay. Now you become a probable case if again you have this set of symptoms and you are a contact of a probable or confirmed case, or you are linked to a COVID-19 cluster, or you are a suspect case having these symptoms with chest imaging suggestive of COVID-19 disease, and these are hazy opacities with peripheral and lower lung distribution, or a CT scan which shows the bilateral ground glass opacities, or a lung ultrasound which shows thickened pleural lines or consolidative patterns. Recent loss of smell or taste without another identified cause will classify you also as a probable case, or unexplained death in an adult with respiratory distress who was a contact of a probable or confirmed case or linked to a COVID-19 cluster. And then a confirmed case is one with a person with a positive RT-PCR or gene expert, positive rapid antigen, and fulfilling the probable case definition or the suspect criteria of symptoms plus epidemiologic criteria of exposure, or an asymptomatic person with a positive antigen test who is a contact of a probable or confirmed case. Okay. So these are the ones that are counted as confirmed cases in our surveillance. Okay. Now let's move to management. Okay. So management is guided by the disease severity. So the site of care management considerations are also guided by the disease severity. So for asymptomatic infection, so these are the contacts, positive on either RT-PCR or rapid antigen, but no symptoms, then we just do quarantine. Okay. So for the mild COVID-19, so these are those with acute onset of symptoms, but no pneumonia, no dyspnea, then they can be managed at home or in a temporary treatment monitoring facility, so as discussed by Anna. And then for moderate COVID, that these are patients who still have good O2 saturation, more than 94%, but with pneumonia on clinical assessment or chest imaging. Under this group also are the elderly and with comorbid conditions with no pneumonia, because we know that they are the ones who are at risk, high risk for progression to severe disease. So they are classified as moderate. And this group of patients can also be managed through a home care program if stable, or in a hospital setting. Okay. Then severe is when you now have a decrease in O2 saturation, then the PaO2, FiO2 is less than 300, and then you have tachypnea and worsening respiratory symptoms. So this is where you now need to move the patient into an intermediate care or ICU for closer monitoring. And critical COVID is when there is now respiratory failure, ARDS, sepsis, or septic shock, and or multi-organ dysfunction. And the site of care is the ICU. Okay. Oh, okay. This is actually for mild to moderate COVID-19. So what are the recommendations for mild to moderate COVID-19? Okay. So again, it's still supportive and symptomatic care, no, for mild to moderate COVID-19. Antipyretics for fever, oral fluids for hydration, and again, isolation at home. Here, I'd like to emphasize routine empiric antibiotics and routine anti-influenza drugs are not recommended for mild to moderate COVID-19 disease. And when the Israeli experts visited us past 2 weeks, this was one of their findings, no, in their visit of the healthcare facilities. They mentioned that we use a lot of antibiotics. Okay. So let's minimize antibiotics for a viral disease, no, unless there is really a strong suspicion of a secondary bacterial infection. So for mild to moderate COVID-19, no imaging or lab test is needed. What we need is close monitoring for signs of progression, particularly dyspnea, persistent fever, and decreasing O2 saturation. So you need at least a pulse oximeter at home or in the isolation facilities. Now let's move to management of severe and critical COVID-19. So unfortunately, no, for mild to moderate, we still do not have very good evidence or trials on the specific antiviral agents. Okay. While for severe and COVID-19, severe and critical COVID-19, which is now when you move into the immunologic phase of the disease, no? When the host inflammatory response takes over, in contrast to the first phase wherein you have viral replication. Here, we do have some, again, the management remains the same, no, actually, with the Delta variant. Okay, so once they move into a severe or critical phase, dexamethasone is strongly recommended. No? So in patients who are requiring oxygen, whether low flow, high flow, or mechanical ventilation. So actually, this was the very first agent that we were able to establish benefit based on a large RCT and then subsequent systematic reviews. No? So like as early as June of last year. No? So we have been recommending dexamethasone, and we have also have now good evidence that we can add tocilizumab to steroids, no? And based on the recovery trial, a big RCT, and then doing a systematic review of the RCTs also show that combining tocilizumab with steroids improve survival, especially among patients who are rapidly deteriorating, needing high dose oxygen supplementation, and those with elevated biomarkers such as CRP. Okay. In particular, in the recovery trial, they used a cutoff of CRP more than 75. Okay. Now, for patients who survive and move into the long COVID stage, no? So we have also the long haulers or long COVID. We also have to consider, no, or we recommend individualized pulmonary rehabilitation, no, with pre-intervention medical clearance for those who show residual respiratory symptoms. No? So to improve quality of life and pulmonary function. So we need to follow up these patients, no, for those who will develop long COVID. Okay. Now, these are a set of interventions wherein the evidence is still low or very low. Okay, so that we just suggest, no, the use of remdesivir, for instance, as an antiviral agent is recommended to be added to dexamethasone among patients who are requiring oxygen supplementation, low flow oxygen, but not yet on invasive mechanical ventilation. And then an alternative immunomodulator is baricitinib combined with remdesivir has also been shown to have good outcomes for patients who are requiring O2 but are unable to take corticosteroids. Then we also recommend prophylactic anticoagulation using low molecular weight heparin, okay, to address the thrombotic episodes, no, as thromboprophylaxis. So we all know now that there are also thrombotic events. No? Endotheliitis is part of the pathogenesis of COVID-19, and this endotheliitis can lead to thrombotic episodes. Okay. So we are actually updating this because there are newer trials that have come out also, particularly on the dosing, no, to whether you are going to use therapeutic anticoagulation in critically ill patients. So at the time that we reviewed the evidence, we did not have yet good data to recommend therapeutic anticoagulation in critically ill patients. Okay, so we will be updating this as well. Okay. Then for those who are already in ARDS, then conservative fluid management is suggested. Self-proning to improve oxygen status is recommended in non-intubated patients. High-flow nasal cannula or nasal cannula oxygenation rather than non-invasive ventilation in acute hypoxemic respiratory failure is recommended among those who do not respond to conventional O2 therapy. Okay. And then rapid sequence intubation is preferred to reduce infection among healthcare workers. And then for those who are on ARDS, a lung protective ventilation strategy is suggested. Now, just a reminder on the interventions where we have moderate to high certainty of evidence already that we should not be using this anymore. So hydroxychloroquine, azithromycin also should not be used. We have very good evidence from clinical trials and systematic reviews that it did not improve outcomes. Tocilizumab and steroids should not be used in non-O2 requiring patients. Okay. So they are only for severe and critical patients. Convalescent plasma also, we now have also trials and systematic review showing that it also did not benefit patients either regardless of the degree of severity. Okay. Ibuprofen, Lianwar, Lopinavir, ritonavir, steam inhalation, again, are also not recommended for COVID-19. And again, just emphasizing again, routine antibiotics is not recommended unless with suspicion of secondary bacterial co-infection. We also suggest against the use of remdesivir if the patient is not oxygen requiring or if the patient is already on invasive mechanical ventilation. So this is based on the systematic review of the randomized controlled trials, and particularly which showed that in this subset of patients, it did not improve mortality. And the benefit that we saw in remdesivir is among patients who are on low flow oxygen or those who are at risk for progression. Okay, so the benefit was more of reduction in the duration of hospital stay, more than mortality. Then for ivermectin, we suggest against the use of ivermectin for severe COVID-19. Okay, we also do not recommend the use of ivermectin plus doxycycline. Okay, and then colchicine likewise, we suggest against the use, except in the context of a clinical trial. We actually await the results of large trials on ivermectin, which is due to come out soon. Around September, we'll probably have results from bigger, high-quality trials. Okay, and likewise for colchicine, there is an ongoing big trial which we are participating also. And this is a drug that may or may have some benefit in mild to moderate COVID-19. So let's wait for that. Then bamlanivimab plus etesevimab. This is an anti-SARS-CoV-2 monoclonal antibody. We suggest against the use in non-hospitalized mild to moderate COVID-19 at high risk of progression to severe disease. Okay. Although we do not have access to this monoclonal antibody. And then these are the set of interventions where there is still insufficient evidence or no evidence. Hence, it should be used only in the context of a clinical trial. So favipiravir, it's a repurposed drug, anti-influenza drug. So there we still have ongoing trials on favipiravir. Okay, so we await the results of those trials. So far, what we've seen is just a reduction in the in viral clearance, shortening viral clearance. That is what is seen in the small trials. Okay, as I mentioned, ivermectin for mild to moderate COVID-19, we still have insufficient evidence. Baricitinib as monotherapy also, there is insufficient evidence to routinely use this. So we suggest against the use. For VCO, we just completed the RCT in PGH and analysis is ongoing. So we'll share that once we have completed the analysis. We do not also recommend the use of inhaled corticosteroids for mild to moderate COVID-19. Then casirivimab plus imdevimab. This is another monoclonal antibody which we still do not have sufficient evidence to recommend, same as leronlimab, hemoperfusion, and hyperbaric oxygen therapy. Okay. Then next, so we've done with the treatment. What is now the recommended days of isolation and quarantine? What criteria do we use to discharge the patient or move the patient from isolation, discharge the patient, and provide return to work clearance? Okay, so for asymptomatic close contacts, we can clear them from work or discharge them remove them from quarantine after they've completed 14 days of quarantine from the last day of exposure, if with negative RT-PCR and if they remain to be asymptomatic. Okay. Now for asymptomatic COVID-19 positive adults, okay, they can be cleared for discharge from quarantine and given clearance if they have completed 10 days of quarantine from the first positive test. And again, if they remain asymptomatic. Okay. Now, for those who are symptomatic, we follow the symptom-based strategy. So for adults with this slide, my slides are cut. Wait. Okay. So we follow the symptom-based strategy. For mild to moderate COVID-19, we can discharge and give clearance from work if the patient has completed at least a minimum of 10 days of quarantine or isolation, no, from the onset of symptoms, and they have been febrile for at least 24 hours without use of antipyretic medications, and respiratory symptoms are improving. While for severe to critical, I'm sorry, the slide was cut off. For severe and critical, the duration of isolation that needs to be completed is 21 days. And the patient should have been febrile for at least 24 hours also, and with improving respiratory symptoms. Okay. Now, the next question is, do we need to repeat RT-PCR test prior to discharge? Okay. So we recommend repeat only among immunocompromised adults, no? So regardless of severity. And we do not recommend repeating the RT-PCR among immunocompetent adults regardless of severity, because it has been shown that it prolongs isolation unnecessarily. So it occupies bed space. No? So it can potentially cause overload in the hospital with patients who are already asymptomatic. And we've seen also, studies have shown that even though they are still shedding the virus, they are non-infectious anymore. So in other words, RT-PCR is not a test of cure. Okay. Now for healthcare workers, you can, depending on your hospital policy, then you can have the option to repeat the RT-PCR and then decide on whether you will send the healthcare worker back to their area of assignment. So this is when we use the CT value, you know, to decide on whether we can send, even if it's positive, but the CT value is high already, then we can recommend the healthcare worker to go back to work. So the policies of hospitals may vary depending also on their human resource complement, also as far as healthcare workers are concerned. Now, in relation to the Delta variant, do we change our recommendations? No. So far, we don't have conclusive data, no, on the difference in duration of infectiousness for the Delta variant. There have been some reports saying that the shedding of the virus is longer, okay, with some low CT values. And I think the recommendation, no, that's for vetting is also, we can at least 10 days minimum or extend up to 14 days, no, for mild to moderate or for moderate COVID-19. But for severe and critical, it's still 21 days. And again, we do not recommend repeating the RT-PCR even if it's Delta variant. Okay. So the only reason during the initial part, when we were trying to characterize or determining the extent of Delta in the country, that we are repeating RT-PCR is to characterize. No? So it's a clinical judgment. No? If you think you see an unusual response, then it may probably clinically you think this would warrant a repeat, then yes, that can be done, but we do not routinely recommend a repeat RT-PCR. Now, to summarize, so for screening and diagnosis, we recommend a symptom screen and together with history of exposure in the past 2 weeks, no, for patients suspected of COVID-19, and then all suspected symptomatic individuals should undergo testing, and RT-PCR remains the gold standard using nasopharyngeal swab. Alternative specimens for RT-PCR are saliva, oropharyngeal swab, nasal swab, while rapid antigen test is a recommended alternative test for symptomatic patients within the first week of illness. Saliva, however, cannot be used for rapid antigen test. Okay. And then there's no need to routinely repeat RT-PCR prior to discharge or for return to work clearance, and genomic sequencing is not for point of care management. For treatment, for mild to moderate COVID-19, It's symptomatic and supportive therapy is the mainstay of treatment. So we need to do close monitoring for progression of symptoms, no routine antibiotics, no routine anti-influenza drugs, isolate for 10 to 14 days. Okay. And then we look forward to the results of ongoing trials on investigational antiviral and repurposed drugs, particularly favipiravir, molnupiravir, ivermectin, colchicine, and the anti-SARS-CoV-2 monoclonal antibodies. For severe and critical COVID-19, it's intensive respiratory management, oxygenation, dexamethasone, plus minus an antiviral remdesivir, and immunomodulator tocilizumab, isolate for 21 days. There are alternative immunomodulators that are being tried now. There are clinical trials ongoing on baricitinib, imatinib, tofacitinib, infliximab, and artemether. And I'd like to mention also that the Solidarity Plus trial, which is moving into phase 2, is about to start, and it is going to investigate imatinib, infliximab, and artemether. Okay, that's it. Okay, just to let you know that again, we are updating the COVID living CPG, and we'll have that published soon also, the updates. Okay, and then the ventilation guidance as well as recommendations on vaccines. These are upcoming guidance. No? So we continue also to monitor the evidence on vaccines. Okay. Thank you. Thank you very much.
Thank you, Dr. Isa. Thank you for reminding us and updating us of our living CPGs. Now, before we move on, we'd like to acknowledge again the other medical societies with us today, this morning. The president of the Philippine Society of Hospice and Palliative Medicine, Dr. Karine Garcia, president of PCOM Laguna Chapter, Dr. Maria Angela Domingo, and from the University of Santo Tomas Hospital and Society of Surgical Oncologists, Dr. Gerald El Cid. We also have here the Philippine Obstetrical and Gynecological Society, Philippine Heart Association, Philippine Society of Ultrasound and Clinical Medicine, Inc., Philippine Neurological Association, Philippine Rheumatology Association, the Philippine Academy of Dermatological Surgery Foundation, Incorporated, Philippine Association of Primary Skin Health Physicians, and the Society of Pediatric Critical Care Medicine, Philippines. Thank you for being with us today. Now we open the floor to our questions from Facebook and here in our chat box. First question is for Dr. Isa or Dr. Anna from Zoom, from Maria Lu Andal. Doc, are there any COVID-19 drug or any monoclonal antibody drugs which are contraindicated for pregnant or lactating women?
And see, I'll answer. Okay. So for contraindicated, all of these investigational drugs have actually excluded pregnancy. So it's really, if it's needed, then we assess the benefit risk ratio. So if it's needed, then we just say, like remdesivir, for example, if it's needed, very much needed, then, or tocilizumab, then we give it, but with consent. Okay. So we have to weigh the benefits and risks as far as management of COVID in pregnant women is concerned. So there's really no absolute contraindication. but they are not included in the clinical trials. Maybe Anna can add.
Yeah, I was just going to say, no, many of the drugs that we're using for these special populations, like pregnant women or children, are actually being used on an investigational basis. So even if we seem to be acting that they're routine, we should remember that we should be getting consent from them. I was thinking kasi from the pediatric perspective, actually walang approved eh. So bawat gamit namin, kumukuha talaga kami ng consent. So I guess it's the same thing also for pregnant and other special populations.
Thank you, Doc Anna and Doc Isa. Next question is for Yusek Rosette. Hi, is the DOH still allowing home quarantine or isolation for confirmed cases with mild symptoms or who are asymptomatic?
Thank you, Casey. Yes, we still allow. No, that's based on the policy naman po kasi. If you will look at our protocols, we allow home quarantine as long as conditions will be met. So kailangan meron po silang sariling kwarto, sariling palikuran or CR, and also there should be or wala po silang kasamang vulnerable inside the house. No, that's something that we discourage na mag-home quarantine kayo kung meron po kayong kasamang matatanda o di kaya mga bata o may taong may comorbidity sa loob ng bahay. Ngayon pong may Delta variant na tayo, we encourage, no, of course, facility-based quarantine. But we also recognize that fact that our quarantine facilities may not be sufficient for all of those who will be going into isolation or quarantine. So we say that home quarantine is still allowed as long as conditions are met. One of the most important things also would be that these patients or individuals who are going to undergo home quarantine will be appropriately monitored. So hindi po pwede na pinayagan natin mag-home quarantine but they are not being monitored. We need to see if the disease will progress and they would need to be referred to a higher level of facility. So these are the things we have this in our existing policies. Yes, we can still do home quarantine, but we need to emphasize that conditions should be there. They can be able to comply with the conditions, and also if there are facilities that they are also interested to go in, mas ini-encourage po namin ngayon ang facility-based quarantine.
Thank you, Yusek. Next question is for Yusek Rosette and Dr. Ranina Gloriani from our vaccine experts panel. What is the best vaccine brand for pregnant women?
Dr. Ranina can answer that.
Well, actually, all of the vaccines that we have available and have been approved are live attenuated, none of them. So actually, they should be safe for everyone. So, but as Dr. Anna, Dr. Isa said, there's limited data on pregnant women and some actually special groups, but those limited data all gave some safety profiles for these vaccines already. So all of them.
So,
But coming up with some live attenuated soon, so there will be different recommendations for those.
Casey, may I just add, Ma'am Nina?
Yes, Doc Anna.
Oo, meron lang kasing specifications yung EUA ng Gamaleya that I think we need to be aware of as practitioners, na yung pregnant and breastfeeding contraindicated. So I would agree with what Ma'am Nina said regarding the general concepts nung wala namang live, so therefore walang issues for pregnant and breastfeeding. Nga lang kasi yung EUA ng Gamaleya, yung pagkakasulat, bawal sa breastfeeding, bawal sa pregnant. So let's just be conscious of that. Thank you.
Also, Casey, I'd like to also add that based from our experts din naman, it should be given during the second and the third trimester of pregnancy so that we can be assured na it is going to be safe for them. And another thing would be that the risk benefit should be discussed also with the individual or the pregnant woman before we give the vaccines.
Thank you po, Yusek, Dr. Ranina, and Dr. Anna. Our Next question is for Yusef Rosette. An observation, I have encountered a handful of patients who were not vaccinated simply because they have maintenance medications. The vaccinators are asking for medical clearance from the attending physician. This alone delays our journey towards achieving herd immunity.
Yes, thank you for that question or comment. No, so as we always say, we emphasize, we do not ask regularly, itong routinely itong medical clearance kung yung mga comorbids naman ay hindi kasama dun sa specify natin. No, so we have these certain conditions that we really would be asking for medical clearance, and that is very clear in our protocols and in our advisories. Yun pong may mga HIV, those undergoing chemotherapy, yun pong nakapag-transplant, yun pong naka-receive ng steroids, yun pong mga frail na patients, yung matatanda na frail na. So these are the certain specific conditions that we have included as advised by our experts that a medical clearance should be part of the assessment of a patient. But other than that, hindi po kailangan ng clearance. What the individuals with comorbidity should only bring with them to show kapag sila ay may comorbid, yun pong reseta ng kanilang doktor for the past 6 months for their medications. Yun pong kanilang medical certificate kung meron sila for the past 18 months actually, because we recognize the fact na nagpandemya na, hindi na masyadong nakakapunta dun sa doktor nila. Maari rin po na mga hospital records like medical abstracts or yung mga discharge summaries nila, or di kaya mga laboratory reports. So we are not asking medical clearance for all of those with comorbidities, only those with specific conditions. We are reiterating this to our vaccination sites para po hindi tayo tumatagal, and rest assured, we will again reiterate because of this comment.
Thank you so much, Yusef. Our next question is for Dr. Raisa. How reliable are the current available rapid antigen tests in detecting suspected or probable COVID-19 cases? If so, can we use it in the community and or workplace setting in our surveillance efforts of active cases, since not all areas have RT-PCR and some of our kababayans cannot afford?
Yep. We need to use the kits that are approved by FDA and then WHO. These are the ones with a sensitivity of at least 80% and specificity of 97%. Okay, so and based on systematic reviews, as I mentioned, rapid antigen tests have at least a 70% sensitivity. So yes, we can use it as an alternative in areas without RT-PCR for those who are symptomatic, and within the first week of illness or in an outbreak setting. So yun yung situations where we recommend RT-PCR. So it's fairly sensitive and specific. Okay, so that's why in our recommendation, it's a substitute for RT-PCR, but not for asymptomatic cases because of the low sensitivity. But if you really don't have access, then you can do it. But if it's negative and you are highly suspecting, then you have to manage the case as if they're COVID-19 positive, especially if you do the other tests and it showed it's compatible with COVID-19, then manage as COVID-19. But if you have the luxury of confirming it with an RT-PCR, then do RT-PCR if you have a negative rapid antigen test and you are highly suspecting COVID-19.
Thank you, Dr. Raisa. The follow-up question po, I think nasagot na, kasi ang tanong is if we consider na confirmed positive na, if positive sa antigen. So pag symptomatic and positive, confirmed and treat as confirmed our COVID case.
Yeah.
So Dr. Yusef Rosette, would you like to add pa po?
I second. I agree with what Dr. Raisa just mentioned.
Thank you po, Yusef. Next question po for Yusek. Good day po ma'am. Tanong lang po kung pwede na po ulit magpabakuna ang mga fully vaccinated na senior ng ibang brand ng AstraZeneca or Johnson and Johnson need need lang po ng guidance.
Yes, no. So you're talking about booster doses. So I think our clinical experts and our expert on vaccines can very well answer that. But I just like to say, no, aside from the safety that our experts are considering for now when it comes to booster doses, let us all try to look at that equity perspective, where in our country, many have still to receive their vaccine. So if we introduce these booster doses already, this might inequitably set aside again those other people who can be eligible not to receive these vaccines that will be given for boosters. But as to the safety side and the clinical side, I'll turn it over to Dr. Nina Gloriani and Dr. Isa and Dr. Ann.
Yes. Actually, this morning we reported to the task group on vaccine evaluation and selection about the possibility of giving third dose in light of the data from Sinovac, especially that those who have been vaccinated had low levels of antibodies after 6 months. So that's a published, actually it's a preprint yet, no? But considering maybe the healthcare workers, so we're really looking at very, very specific populations. If ever, we will recommend it, or the All Experts Group will recommend it. So the healthcare workers who are really exposed to COVID patients, those who are also relatively elderly among the healthcare workers and with comorbidities, and also looking at the immunocompromised. So we have identified certain groups who may benefit from that, but saying also that the benefits for these particular groups for booster doses will have to outweigh the benefits that will be given to the or the risk of the general population not getting the vaccine. So that still has to be well decided and discussed, especially with NITAG and HTAG.
Thank you, Dr. Nina. Our next question is for Dr. Anna. Are the box-like units using UV for disinfecting like respirators or infant bottles, are they still okay po?
Yan yung mga yung mga home UV disinfection kits. In general, no, tandaan natin, ano ba yung purpose ng UV disinfection? Di ba pang ano lang yan, last step lang yan after making sure that physical disinfection and physical cleaning and disinfection have been implemented. So, kung gagamitin natin tong mga to, dapat aware tayo kung ano yung rated capacity. Alam natin na yung surface lang na iniilawan yung maapektuhan, no? Yung kabilang surface hindi yan madidisinfect. And in general, alam niyo pagka malinis, kung nalinis naman natin physically yung item saka with appropriate disinfectants, wala namang masyadong idadagdag na yung UV. No? So siguro on a day-to-day basis, saan kaya natin yan gagamitin? Baka phone lang ang magkakasya dun sa mga yun di ba? So I really don't think it adds too much to just very standard interventions that we are all that's really time tested.
Thank you po, Dr. Anna. Next question po. I think all our experts, even Yusek, can answer this. Is there a possibility to prevent further influx of new variants of interest in our country, such as the Lambda variant, which is probably resistant to vaccines, by increasing quarantine policies or incoming individuals abroad? I met OFWs that were sent home only after 5 days or 7 days. Prevention of new variants will surely help decongest our healthcare system.
Yes, PC, actually, katulad po nung I have presented a while ago, we are implementing the four-door strategy. And the first door there would be our stricter border controls, no? The doors 1 and the door 2. Kailangan lang po natin maisip or we need to be informed that our quarantine protocols had been revised to make it more rational and to make it more stringent. So dati po, ang ginagawa natin, we test all of the incoming travelers the first when they arrive. And then kapag nagkaroon na po sila ng resulta, nakapayagan na po silang makauwi. But after having some discussions and evidences were there, our experts have recommended, our TAG experts have recommended this 7th-day testing and 10-day facility quarantine at the national and another 4 days in the local government. With this newly revised or this revised protocol that we've had, we were able to delay the entry of the Delta variant here. So kung matatandaan po natin, nagkakaroon na ng pagputok sa India, pumutok sa Indonesia, sa Malaysia, and the other countries. Pero tayo, we were detecting Delta variant at our borders. These were the OFWs that we have. So that means that our whole genome sequencing and our border controls were were being implemented, no, and it's effective. Aside from that, from the border control na yun, meron tayo pang travel bans among these countries that we saw na may pagtaas ng kaso. So now with this Lambda variant and the other variants of interest na lumalabas pa rin, it's the same way that we will do it. Yun pong mga breaches na ganito, hopefully it can be reported officially to us so that we can address it. But basically, we are implementing stringent protocols right now. We do not accept exemptions for those incoming travelers, even if it's humanitarian. Ang binibigay lang ho nating exemptions are urgent or emergency medical reasons ang binibigyan natin ng exemption. Aside from that, we are not allowing anybody to go through our borders na hindi po nakakapag-comply dito sa quarantine protocols natin. Please.
Thank you, Yusek. Our next question is for Dr. Ana. Good morning. What would be an option regarding the identification of cases for families who have asymptomatic adult family members but have symptomatic pediatric family members who have been turned away by the LGU for swabbing because of their age? Ayaw daw tanggapin because bata pa yung pasyente po.
Implementation issue, no, Casey? Pero siguro from the practitioner's perspective, medyo feel ko yan kasi we had a recent situation like that eh. Ang kwento naman doon is nagkasakit yung parents, hindi nagpa-swab. Tapos ngayon na may sakit na yung mga bata, syempre iko-konsulta nila at wala kaming choice kung hindi iswab. So medyo napagsabihan ko tuloy yung aking team na ito na nga nakikita na natin, di ba? Dapat talaga yung adults ang pinaswab para alam natin kung paano minamanage yung bata. So in this case, malamang lampas na dun sa panahon kung kung kailan natin pwede sana makakuha ng effective result from the parents. Kasi parang yung sequences, nauna magkasakit yung parents, tama ba?
Asymptomatic daw po yung parents.
Asymptomatic yung parents.
So yung pedia patient lang yung may symptoms to.
Okay. So in this case, may mga facilities naman na gumagawa ng swab, no? So hindi naman yata valid yung tinurn away kasi bata daw. Baka naman yan doon sa mga TTMF or yung mga, I don't know. Pag tertiary hospital, definitely isa swab yung batang yan. So siguro maghanap na lang tayo nung facility kung saan pwedeng gawin. Pero siguro i-reverse ko rin yung situation. No? That's an additional reason why adults can be encouraged to swab. Kung meron kang vulnerable sa bahay, ayaw mo naman yung vulnerable pang ipapaswab mo, di ba? So, incentivize natin by using that particular framing kung makakatulong. Thank you.
Doc, meron ba, follow-up lang po, meron bang specific age na parang limit for us to test mga pedia patients? And is there a specific way po on how to swab ang mga pedia patients natin?
Actually, pati newborns, di ba, sinaswab naman natin, lalo na kung delivered to positive mothers. So actually, kahit anong age pwede. Ang ano lang nun, ang katapat lang nun yung kung gaano kapino yung ginagamit nating swab. So meron talagang smaller swabs that we use for pediatric patients. Pero maa-eyeball mo naman yun eh. Wala naman yatang swab na sobrang laki na hindi papasok dun sa ilong ng bata. So pwede talaga siya. Technique lang ang kailangan, mabilis lang dapat. Sanay na naman tayo after 1.5 years. Kayang-kaya na natin yan.
Okay, thank you po, Doc Ana. Next question, for Yusek Rosette. Will vaccination programs still be operational while ECQ? Just want to raise a concern that some vaccination centers are now using only photocopy of vaccination cards. And I also saw that people are merely printing vaccination cards without getting the vaccine.
Yes, no. So for the first question, we will continue to vaccinate even under ECQ. So one of the objectives and one of the strategies that government will do, as recommended by our experts, would be to increase vaccination during this time that we will have our ECQ. Although we will not feel the effect yet for this maybe first weeks of the ECQ, but we know that eventually we will get more people or individuals fully protected, no, and that will give us a chance, no, to battle, no, this Delta variant. Tuloy-tuloy po ang pagbabakuna. We will be ramping up vaccination during this ECQ period. There was this commitment already coming from the vaccine cluster na magbigay ng mas maraming bakuna po dito sa Metro Manila, sa plus areas ng Metro Manila, pati po yung mga highly burdened areas in the country. So that would be one of the strategies for us to be able to combat, no, this Delta variant. Pangalawa, yung sinasabing nagpiprint po ng mga vaccination cards lang at nagkakaroon na kahit walang bakuna. Again, let me just request from our colleagues here and sa public na kung sakali po na meron kayong alam na gumagawa nito, please inform us at once so that we can be able to address it immediately at hindi na po lumaganap ang ganitong practice. We all know that this is very important for all of us because we are counting, we are trying to target, no, this certain percentage of the population that will be vaccinated so that we will have that protection for the population. So we are not going to tolerate this kind of practices and this is not acceptable. So please report it to us so that we can be able to address that.
Okay. Thank you, Yusek Rosette. Next question is for Dr. Ana, pero parang kasama na to sa na-discuss ni Yusek Rosette earlier. Maybe to reiterate lang, ma'am, kailan ang vaccination ng children? Doc Ana.
Oo. So, tama ka, Casey, no, nabanggit na kanina as part of the general strategy. Unang-una, tandaan natin, ano ba objective natin sa pagbabakuna? Hindi nga ba para ma-decrease natin yung risk of severe disease and death? So, following that line of thinking, sino ba ang nasa risk ng severe disease and death? Siyempre, yung A2 at A3. So, using that line of reasoning, malayo-layo pa ang pediatrics kahit na nababalitaan natin na medyo mas maraming bata relatively ang naapektuhan at mas marami daw supposed to be ang severe ang presentation. So, again, no, bilang pediatrician, medyo nakakalungkot yan kasi syempre gusto ko mga bata kasama sa bakunahan. Pero siguro if we think about it from the cocoon strategy perspective, hindi naman dehado ang mga bata kasi sino ba kasama nila? Di ba household lang naman, di naman natin pinalalabas sa mga bata eh. So kung lahat ng vulnerable sa household ay nabakunahan na natin, para na lang din na proteksyonan natin yung mga bata. So ang emphasis pa rin, balik tayo, A2, A3, yung mga A4 na qualified kasi naglalalabas yan. Tapos kung wala silang sakit, hindi dapat magkasakit yung mga bata.
Thank you po, Doc Ana. Our next question, those fully vaccinated, are they also required to have RT-PCR or antigen tests once admitted or for admission in a hospital? I think, Yusek Rosette?
I think sila Dr. Isa and Dr. Ana because they work in the hospital. But I just like to tell everybody that all of our hospitals have COVID and non-COVID section. So para lang po, we don't mix them together and we prevent infection. So maybe Dr. Isa and Dr. Ana can give the response.
Casey, can I just start off? No? So siguro yung principle na kailangan nating maintindihan dito, pag nabakunahan na, di ba, hindi naman tayo nag-guarantee ng sterilizing immunity or transmission blocking. So therefore, kung pwede pang mahawa at pwedeng mahawaan yung na-vaccinate, it stands to follow na pag nag-a-admit tayo, kailangan pa rin natin sila i-RT-PCR para meron tayong paraan na malaman kung saan natin dadalhin sa ospital itong pasyenteng ito, kung doon ba sa COVID or sa non-COVID area. It's an infection control strategy, no, para mapigilan natin yung pagkalat ng COVID or mixing of COVID and non-COVID patients.
Okay. Thank you po. Dr. Isa, would you like to add po?
Yeah, I agree with what Anna said, no? Especially sa surgery, ganyan din, no? For those who are admitted for surgery, they need to undergo RT-PCR also within 72 hours prior to surgery. Same as what Anna said. So, kasi our vaccines are not meant to prevent transmission of infection at this time.
Thank you po, Dr. Isa and Dr. Anna. The next question, I think parang follow-up po dun sa issue kanina, dun sa mga nagfa-falsify ng mga vaccine documents. Where can we report cases or errors in screening po or yung mga clearance sa vaccination sites or people falsifying vaccine documents?
You can send it to us po sa DOH and we will try to address all of these issues, no? So you can see Casey po, our secretariat, will be posting in the chat box email and our other social platform addresses so that you can be able to reach us through these platforms para po yung mga comments niyo po ay mai-consider at mai-relay po natin sa agencies na concern.
Okay. All right. So that would be the last of our questions for this morning. Can I request na lang po any short messages from our experts with us today? Maybe we can start po with Dr. Nina Gloriani.
Yes, I've always said this, no? We were experiencing a spike in these cases, and what we really have to do is to stop the transmission. So we go back. Of course, we need the vaccines, but we go back to our minimum public health standards, because the more people are infected, the more virus you have, the more mutations you get, and there you go. We may have another variant that is even fiercer than what we have now. So back to the basics.
Thank you, Dr. Nina. Next po, Dr. Anna, a short message.
So bilang healthcare practitioners, ang dami nating dapat paghandaan. And ang laki talaga ng voice, no, na dala natin to be able to make an impact within our networks. So I hope, no, nagamitin natin ng maigi yung ating influence, particularly to share information about vaccination, the need to prioritize our A2 and A3. Para sa mga pediatricians, no, siguro we can inform families na the way to protect their kids is to make sure that their A2, A3, A4 in the families are protected with vaccination. Tapos, siguro yung isa pang paalala is that we really need to work on shortening the interval between symptom onset and identification of a positive case. So kasama dito yung behavioral aspect, kailangan nating kausapin yung ating networks na wag nang patagalin pa ang testing at i-implement right away yung isolation and quarantine within the households. Ipaintindi natin sa kanila, no, kung ano ba yung sapat na duration ng isolation and quarantine at kung bakit mahalaga na sumunod ang mga tao dito sa mga regulations na ito. And finally, no, habang hindi pa stressed ng husto yung ating healthcare capacity in the NCR area at least, no, siguro turuan na rin natin ang ating mga pasyente, ang ating mga networks kung papaano sila effectively makakapag-access ng telemedicine services para kung kailangan na nila, hindi pa lang doon naghahagilap at nagpapanik. Maraming salamat.
Thank you, Dr. Anna. Next po, Dr. Isa, can we have a short message? Naka-mute po ata kayo, Dr. Isa.
Again, we need to practice PDITR plus vaccination. So prevention and early detection is primary in the control of COVID-19. So it's really a bundle of interventions that we need to continue to enhance and sustain, actually. And it requires really collaboration, solidarity among all sectors. So especially dun sa prevention nga, that's yung minimum health standards natin, which includes vaccination. And sustaining is what is important. Yung back to the basics, but sustain it. And of course, vaccines. You know that it's still, a lot of it is still experimental, but we're lucky that the trials, actually tulong-tulong din ang mga companies producing the vaccines, because we need to supply everyone with the vaccine. So let's boost vaccine confidence also. So, hindi lang kaya it's several pillars and bundles of intervention that we need to sustain in this fight against COVID-19. Thank you.
Thank you, Dr. Isa. We also have here one of our resource persons, our Assistant Secretary from the Administration and Financial Management team, ASEC Maylene Beltran. ASEC, would you like to give a short message po?
Hi, yes, good afternoon, everyone. Thank you very much for this opportunity. Actually, it's I who learned a lot from our resource persons. But anyway, again, to all our medical practitioners, let me just take this opportunity to thank you and to say mabuhay kayong lahat for your selfless and very invaluable contribution as we fight the COVID disease. So with that, kung may questions lang po, because I have been taking charge of benefits as well as compensation for healthcare workers, feel free lang po to keep in touch through USEC Rosette's team, and we will be addressing your queries appropriately. So with that po, maraming salamat. Thank you.
Thank you, ASEC Maylene. And now to officially close our town hall for today, may we have again on the floor our OIC Undersecretary for Health and the official DOH spokesperson, Dr. Maria Rosario Singvergere, for her closing remarks.
Yes, thank you, Casey. Bago po tayo magtapos, gusto ko munang pasalamatan yung ating mga experts na lagi po tayong sinasamahan, and yung suporta nila mula nung nag-umpisa ang pandemya. We have Dr. Nina Gloriani from our vaccine expert panel, Dr. Marisa Alejandria and Dr. Ana Ong Lim from our technical advisory group of experts, and of course our Assistant Secretary Maylene Beltran from the DOH team. Gusto rin po naming ipaabot mula sa Kagawaran ng Kalusugan ang taus-pusong pasasalamat sa inyong lahat. Alam po namin, kasama po namin kayo mula nung umpisa dito sa laban natin sa COVID-19. We know how tirelessly yung inyong efforts para po maisalba natin ang ating mga kababayan kapag sila po ay nagkakasakit at napupunta sa inyong mga institusyon. Kasama rin po natin ang mga different societies, medical societies here in the country, na alam po namin suportado nyo kami because you see that we use science and evidence in all of the decisions that we make. At ang kasama po naming mga eksperto ay mga kasama nyo rin po sa inyong mga societies. So just to end this forum, I just like to remind everybody that no matter what data we see right now, no matter who says or who gives that data, kung hindi man po gobyerno yan, kung iba pa hong mga research institutions, kung iba pa hong mga eksperto, lahat po ng sinasabi namin ngayon ay iisa. Tumataas sa mga kaso at kailangan na po nating umakto ngayon. So that is our main goal right now. We do not like to dwell on the projections, the numbers, the data. We all would want to gear everybody towards that direction of acting now. And that is what is most important for all of us. So all of you from the healthcare sector, sa mga institutions nyo po, alam ko you are feeling already na pataas na yung ating mga number of cases, na andyan na po yung mga pasyente uli. Hopefully, we can all work together. It is just through working together that we can all be able to surpass all of these challenges that we are facing right now. Please always remember, we are not defenseless. Nagdaan na po tayo sa ilang mga pagsubok dito po sa pandemyang ito. Nagkaroon na po tayo ng ilang beses na pagtaas ng mga kaso. We had the July to August increase in cases. We had the March to April, and now we have this. And we have learned a lot already. We have seen how our healthcare system have matured, especially yun pong ating mga clinical management, our protocols for the community, our protocols in the hospitals. Ang ating pong mga doktor ay mas may armas na ngayon para gamutin ang ating mga pasyente. We were able to establish facilities already. We were able to expand our resources, and we have the vaccines now. So we are not defenseless. So sana po, sama-sama po tayo, we can be able to overcome, we can be able to save as much lives if we can all together implement the protocols and encourage everybody who are eligible to get vaccinated now. So yun lamang po, maraming salamat po sa inyong lahat, and hopefully we will all see this through. Be safe everybody, and God bless all of us.
Thank you po, Yusek. So that ends our town hall for today. Thank you again to our medical practitioners for your continued selfless work and cooperation. Have a great day po. Bye.
Thank you.
Thank you.